We are going to present the CSF gusher during cochlear implantation. Normally, this term is old, the perilymphatic gusher. Now it's replaced by the CSF gusher. For a long time, when the surgeon finds a gusher or an egress of fluid coming after cochleostomy, he termed it CSF, a perilymphatic gusher. This is not true, because as we know, the perilymph is in few millimeter and will never exceed 2 or 3 millimeter, while the CSF is normally large in amount. So the term CSF gusher have replaced the term the perilymphatic gusher. Normally, CSF can access the cochlea either through an abnormal developmental pathway of the otic capsule or after traumatic disruption of the temporal bone. Abnormal wide internal auditory canal, common cavity, large vestibular aqueduct, Mondini malformation, and Pendred syndrome are considered gusher-prone inner ear malformation. These anomalies are preoperative known risk for intraoperative gusher, and until 1994, they were considered relative contraindication for cochlear implants. However, the FDA have approved it owing to the minimal complication and the reasonable audiological profile gain after surgery. The majority of the labyrinthine anomalies usually become uncovered with preoperative imaging. However, unexpected CSF leak may occur at the time of cochleostomy, whether round window approach or ordinary cochleostomy, in the absence of preoperative radiological evidence of congenital inner ear malformation. We experienced 8 cases over the last 6 years. Half of them was Mondini and large vestibular aqueduct, either isolated or with each other, and the remaining 2 cases with congenital inner ear malformation, one wide internal auditory canal and one with a common cavity malformation. No bony malformation was found in 2 of them. One of the 2, the CSF developed not from the site of the cochleostomy, but from the area of the well housing the receiver stimulator complex. Here we can see this can occur usually in children with very thin skull bone, injury of the dura during drilling this tunnel, which the electrode will pass from the bed to the mastoid, and can be easily controlled by tucking a piece of muscle or fat under the bony edge. Rarely, lumbar puncture may be used for 3 to 4 days till healing of the dural tear occurs. First, Mondini malformation. It's the most common congenital inner ear malformation. It occurs due to arrest of the development at the 7th week of intrauterine life of gestation. The cochlea comprises only 1.5 turn instead of 2.5 turn due to confluence or scalar defect in the region of the apex of the cochlea between the apical and the medial turn of the cochlea, while the basal part of the modulus is present, so the basal turn is present. It's termed the incomplete partition type 2. It's one step behind the normal cochlea. So we have a normal cochlea, Mondini, and incomplete partition, and common cavity. Here we can see cross-section of the cochlea with a Mondini malformation. This is the basal turn of the cochlea, and we can notice the confluence between the middle and the apical turn due to interscalar septal defect or absence. The modulus is malformed with segment of spiral ganglion missing, and the osseous spiral lamella and the Reisner's membrane here is deformed. However, it's not the main finding in Mondini, maybe due to the preparation, H&E preparation. This is preoperative radiological findings. Here we can see in the coronal section 1.5 turn, while in the axial section we can see sure confluence between the apical and the middle turn of the cochlea. So, is it common that Mondini malformation during cochlear implantation will develop CSF? This is not true. In isolated Mondini, the cribriform area, which is a very thin bone separating the cochlea from the internal auditory canal, and the basal part of the modulus are present. So it's less likely to develop CSF gusher. And if it occurs, it's due to association with other congenital malformation, which is the large vestibular aqueduct syndrome. The neural architecture in cases with Mondini is much more organized than the common cavity or incomplete partition type 2. So it is nonsense to mention that a Mondini is a contraindication or even a relative contraindication for cochlear implantation. Unfortunately, most of the cases of Mondini, more than half of them, usually associated with other congenital inner ear malformation, especially the large vestibular aqueduct, which is, here we can see, this is Mondini malformation. This is the basal turn of the cochlea with the confluent apical and middle turn associated with very wide internal auditory canal and very large vestibular aqueduct. So again, the development of gusher during cochlear implantation in cases with Mondini is less likely to occur unless associated with large vestibular aqueduct. Large vestibular aqueduct, the syndrome is a radiological syndrome or radiological definition, is a vestibular aqueduct whose diameter is 1.5 millimeter or more on CT. Or, I don't know, is it good? You can see well or no? I don't know why. The resolution is very bad. Or a vestibular aqueduct whose diameter is more than half of the posterior semicircular canal. Let's try to enlarge. Sorry for that. This is the vestibular aqueduct and the posterior semicircular canal behind it. The vestibular aqueduct whose diameter is more than half the posterior semicircular canal is termed as large vestibular aqueduct. Many classifications of the large vestibular aqueduct, however, the most important thing is large vestibular aqueduct is usually associated with other congenital and genetic syndromes, the mostly Mondini malformation, modular defect, ranging from a common cavity, passing through the incomplete partition type 1 and ending in incomplete partition type 2. However, no correlation between the degree of large vestibular aqueduct and the degree of modular defect, only to the degree of hearing loss. It only correlates to the severity of the CSF gusher during surgery. This is a case with Mondini malformation which developed gusher during surgery. The gusher was very few. You can see very mild ooze. It's better to be termed CSF ooze rather than definite gusher. This gusher stopped spontaneously after few minutes, and we were able to introduce the electrode array easily without any further gusher. This was a case of isolated Mondini malformation. This is just a piece of fascia or periosteum to support the electrode to avoid recoil and not to stop any gusher, which is no longer present. This is another case with Mondini and large vestibular aqueduct. The gusher was severe. We can see continuous suction didn't stop, and the gusher continued to flow. Here we can see the gusher is coming out from the cochleostomy site around the electrode array. We need to pack the cochleostomy site, not the basal turn, with small pieces of muscle and fat around the electrode array, and was sufficient enough to stop the gusher, as we see. This is the cochleostomy site and the electrode passing through it. And gusher stops only after sealing the cochleostomy with small pieces of muscle around the electrode array as it passes to the cochlea. Here the CSF gusher stops totally. This is the post-operative radiology. We can see coiling of the electrode array in the confluent apical and middle turn of the cochlea. Normally, in cochlear implantation, the X-ray post-operative in the Stenvensen's position show 1.5 turn only. The cochlea turn 1 and another turn here, more than 2 turns, indicating confluence of the cochlear turns. This is the post-operative or immediate intraoperative electrophysiological assessment. No responses on the apical turn of the cochlea. Also no responses was noted in the basal turn of the cochlea. However, few weeks later on, basal responses start to appear, very good and very nice waveforms. The common cavity, which is the last entity, is a cystic cavity representing both the cochlea and the vestibule due to total absence of the interscalar septum, leading to common cochleovestibular chamber with very poor neural population, spiral ganglion neurons. It's usually associated with abnormalities in the internal auditory canal, with wide internal auditory canal and large vestibular aqueduct, and patients with common cavity usually experience the most aggressive perilymphatic or CSF gusher due to a bony defect in the cribriform region between the internal auditory canal and the subarachnoid space, so continuous CSF leak. This is a common cavity. We can see the confluence between the cochlea and the vestibule. No septum at all, or no separation or landmarking of any component of the vestibule, of the labyrinth of the inner ear. And this is after insertion of the electrode array. Here is the electrode passing through the mastoid, and we can see it inside the cavity. Here, packing of the cochleostomy itself will not be sufficient. We need to pack the whole cavity to stop the gusher. Also, packing is of value not only to stop the gusher, but to lay the electrode array towards the wall of the common cavity. Otherwise, it will float inside the cavity. So as to stimulate as much as possible as we can from the spiral ganglion neurons, which is already sparse and very poor in this congenital inner ear malformation. This is a common cavity. We need to pack the whole cochleostomy, which is not sufficient. We need to pack the whole basal turn of the cochlea with muscles and fat and periosteum to stop the CSF and to lay the electrode array towards the wall of the cochlea. Here we can see the cochleostomy site and continuous egress of CSF. This is the electrode array passing easily, but without stopping anything. The only problem when you face like this, or the problem with when you introduce the electrode through the cochleostomy site while you experience CSF, is you will find yourself, the fluid, the clear fluid will do refraction to your eyes when you are looking through the microscope. You may be vigorous manipulating the electrode, will lead to breaking of the electrode or putting it in elsewhere rather than the cochleostomy. It's not an easy procedure to introduce the electrode while CSF is coming. This starts to be less, but still continuous. We need to pack around the electrode. Continuous packing of small parts of muscle towards the basal turn of the cochlea, towards the cochlea cavity. You can see the piece of muscle is extruded by the pressure of the CSF. The whole cavity has to be packed, even with pieces of gel foam. Sometimes we use what we term the avetine, which is no longer approved by the medical ethical committee in our country because it comes from bovine materials. Here the CSF almost stopped. If we didn't experience any stop of CSF, what we are going to do, we didn't experience any case. We need to remove the incus batris, we need to pack the whole middle ear, and then we need to close the eustachian tube as well. This is the post-operative audiological performance. This is a case with cochlear implant, nucleus cochlear implant. We were able to do the testing in the common ground and the monopolar and the bipolar mode of stimulation. Here we can see more than 1 point of reversal, indicating that the electrode, here this is 1 point of, this is reversal point and this is reversal point, turn over itself. In the monopolar mode, very poor responses is noted, absent wave 5 or almost absent wave 5 in all 22 channels. So the common cavity is a congenital inner ear malformation. The results of cochlear implant among this group of patients is usually subsatisfactory, not because of the gusher, but because of the poor spiral ganglion neurons. Poor spiral ganglion neurons is detected by the poor wave 5 in the electrical ABR testing. So, 1 year after surgery, the post-operative audiological performance was excellent in cases with no pathology, no congenital inner ear malformation, followed by the large vestibular aqueduct isolatedly. And the worst results was found in the common cavity, followed by Mondini malformation. Even that Mondini didn't develop that strong gusher. So we concluded that CSF gusher is a surgical difficulty or an operative challenge rather than a bad prognostic determinant for the post-operative performance of patients. In congenital cochleovestibular malformation, the more the degree of involvement of the cochleovestibular apparatus, but not the amount of gusher, the more we expect poor patient performance. And lastly, we were able to conduct a simple stepwise roadmap algorithm for the management of gusher. If you face gusher during surgery, don't get panic. Start to elevate the patient head to decrease the intracranial pressure. Insert a piece of gel foam in the cochleostomy and decrease the end-tidal carbon dioxide below 28 and wait for a few minutes. If the gusher stopped, proceed. If it didn't stop, also proceed, but be cautious because the clear fluid will cause some rarefaction to your vision while insertion. Try to insert the electrode and wait. It might stop the gusher totally. But if it's not stopped, try to seal the cochleostomy with small, fine pieces of muscle. Don't be aggressive in insertion of muscles because you may insert it at all, isolating the electrode from the surrounding walls of the cochlea. So preventing any stimulation of the spiral ganglions in the wall. If no response, pack the whole basal turn of the cochlea with muscles, and we will depend upon stimulation of the apical and the middle turn. If no response, obliterate the middle ear and pack the Eustachian tube with muscles. We didn't use lumbar drain in our cases at all, but it might be used with carbonic anhydrase for a few weeks after surgery. Thank you, and sorry for the resolution. I was not expecting that Prezi will not work in this system. I'm sorry? No, one of the pieces you remove.